Yeah, people can be putting their names in the chat and stuff in their facilities.
Good afternoon, everyone. While we're getting everyone admitted, please put your name and facility in the chat so we can keep track of attendance. I'm going to make sure you get credit for attending. And welcome to the March KPQC Learning Forum. Carrie, I'll hand it over to you if you want to get us started, or if we can wait also.
No, we're going to go ahead and get rolling just to be respectful of everyone's time. Thank you guys so much for joining us today. Tara is working through some tech issues because it would not be um, an online event if we didn't have some sort of tech event that happened. So just like Tiffany said, if you guys will go ahead and put your names and your hospitals in the chat and um, I see Tara jumping in, so give us 2 seconds. There she is. I love it. Great job, friend. All right, now she just has to unmute. You guys have all seen this map before. It's just a map that we have that shows all of our birthing facilities and our non-birthing facilities, in addition to the green hearts that we added last month, which indicate our 7 sites that are currently participating in our cuff pilot project. So that being said, go ahead, Tara, when you're ready.
Am I ready? Can you guys hear
You
me okay?
you're killing it. You're so
What is
ready.
happening right now? I love Zoom. Everyone loves Zoom. Guys, welcome. It's so good to see everybody. What a great group we have. I see people just flying in from all over the state. So, thank you for joining us over your lunch hour. Um, this graphic is, again, a testament to the widespread reach of our KPQC work across the state. Obviously, and I'm sorry, Carrie, if I'm repeating what you just said, but the red hearts are our birthing facilities across the state. I was looking at birth numbers for 2025. Very interesting. Some increases, some decreases in birth numbers, some closures, some pull-ins from other counties. This is just really interesting to watch. And our birth center, or excuse me, our birth facility numbers in general, we'll give you that total in the next month or so in terms of what percentage we're affecting, but we're hitting the majority of births in Kansas. That's our goal. Now, what's pretty awesome too is those blue hearts. Those are our non-birthing facilities that raised their hand and said, we believe that we're part of the answer. We know patients come here pregnant and postpartum and want to be part of the fix of maternal hypertensive disease in pregnancy and postpartum, and are changing protocols and doing a better job of taking care of women in Kansas along with the rest. The Green Hearts are our cuff pilot project sites. They were identified as high risk counties and raised their hand and said, we want to put cuffs in mom's hands and patients' hands and see if we can get them into care faster by them self identifying hypertensive disease in the home and get them in for care, and then we'll take over for timely treatment. Pretty awesome stuff happening across the state, you guys. Just wanted a reminder of all the things um, that are occurring literally west, east, north to south. Great job, everybody. Next slide. And then for those of you that are enrolled, so our birthing and non-birthing facilities, we're really excited to share with you all. Again, the registration link is there, and then our agenda on the right-hand side with our featured speakers for our in-person workday, May 1st. One enrolled champion plus, and a plus one, meaning your coworker plus one. I guess if you bring your significant other, we'll just wish them the best. But assuming that plus one is your co-champion or your colleague, we are thrilled to have you all in person in Topeka on May 1st. As you can see, we have a dynamic group coming to speak with you all. And we're excited that this will lead into hopefully our virtual conference being even more robust for everybody in the state to get a chance to hear more in the fall. But these are the focused speakers and excited. So please register. You'll get a nudge from us, champions, if you haven't registered pretty soon. So excited to see you all there. Next slide. Kansas Birth Equity Network, long-term collaborating group, statewide work on birth equity. Those of you that were with us for fourth trimester and since know that they do tremendous amount of training across the state on the patient side, provider side, community side to encourage birth equity in our state. And they have this really cool new idea called the Mom, Dad, and Baby Expo. You can find out more information there. Tiffany always sends out these slides, the slide deck, and the links associated. So the QR codes will be included, the signups there. Share widely, those of you that are able to do so, and excited for them and happy to share that information out. Next slide. Carrie and I always find it our responsibility, quite frankly, to get out updates across the state. They may be state updates on maternal pediatric health. It may be national updates. It may be some food for thought. We call them rapid responses. We've done that since, years ago. And there's some conversation happening again around ROGAM and the provision of ROGAM, when it should be given, when you don't have to worry about giving it, et cetera. And I'm just going to flash on this. It literally could be an entire learning forum, and we may do that because I suspect that this will create some questions, unless you've already tackled it at your site. But literally kind of an update on when it should be given, by week's pregnancy, by, we'll call it encounter or event, miscarriage, for example. Recommendations have changed a little bit on that. So the link is there at the bottom. Again, you'll get this slide deck when you go out. If you have further questions and want more references, we're happy to provide. Next slide. Carrie?
Yeah, carrying on with what Tara said, some more articles that we wanted to share out. Maternal Fetal Medicine went ahead and offered an updated statement that supplied checklists for your preeclampsia risk factor screenings for those who they recommend to receive prophylactic low-dose aspirin. So the second snippet that you see on the bottom right is actually the checklist itself. I encourage you guys, if you don't have access to this article, we provided the link there to get that. And then if you have any questions at your facilities or know any providers who are kind of pondering each way, you can offer a resource for that guidance. Next slide, please. Another article, I actually thought this was really interesting, that indicated early pregnancy depression symptoms and its tie with severe maternal morbidity. And what the study showed was a pretty strong association between maternal mental health in early pregnancy and subsequent severe maternal morbidity. So it highlights the importance of not waiting until postpartum before we start screening for mental health and what role it can be playing. That needs to happen very early on in prenatal care and followed throughout the duration of, as well as supplying the Edinburgh, so whatever resource and tool you guys use at your facilities to screen for it. But I encourage you guys to take a peek at that article as well. Next slide. So I've had some questions, especially as I have been stalking everyone to get their data from them. A lot of questions related to why would we be encouraging patients to be seen, and not we, why are the governing bodies and the recommendations out there to encourage patients to be seen at 3 days versus 7 days versus 6 weeks postpartum. And this is another article from Society of Maternal Fetal Medicine. On the bottom left, you'll see a snippet where it kind of compares the bottom traditional period of recommendations for follow-up with prenatal visits versus the right-hand side is a snippet of SMFM's guidance and recommendations, especially related to those with hypertensive disorders, gestational diabetes, and your cardiovascular disease. I just want to highlight the importance of remembering that the 72-hour visit is for those specifically with severe hypertension, those women who had those acute treatable blood pressures, as opposed to the 7 days, which is more recommended for those who had their chronic hypertension that they came in into the pregnancy with. So take a peek at that. If you have any other questions, the link to the resources there, reach out to us. Next slide, please. And Tara, I'm going to hand this back to you.
This is just, again, conversation of how do we schedule and birthing versus non-birthing facilities. I think helpful. I'm thinking emergency departments and when you see postpartum patients as well. But regardless, this is an old slide. We use this in the fourth trimester initiative to talk about, how do we make sure that patients have follow-up and how much do we handhold? And the answer is we should be handholding quite a bit. We should be making appointments or giving them exactly who to call and what kind of appointment to ask for. We're still finding, especially in the hypertensive bundle, that what does the appointment need to be and with who is that being asked quite a bit, and how do we make sure that that's happening, and what interval do they need to be seen? So, AWON and ACOG have made multiple attempts to make this as easy as possible with algorithms and workflows just like this one. I just shared this out because it's available on our website, but it talks about, how are you documenting? How are we making sure that the patient knows when her next appointment is going to be if it's not made for her prior to discharge? And, again, education happening all the while of, hey, it's really important that you are seen postpartum. Here's why. Here's the interval you need to be seen. If you have concerns before this, of course, we've reviewed post-birth. We want to see you sooner, etc. So just a revisit and reminder about the postpartum visit schedule and why and how we document that on the inpatient, outpatient side. Next slide. Carrie, I'll take that one. The story here, you guys, for those of you that don't know or haven't seen it, the lactation, medications and lactation resource guide put out by the Kansas Breastfeeding Coalition is awesome. I think we shared it out to the listserv. If not, we should. It will be in this slide deck again, and then it's referenced on our website as well, on the KPQC website. Really, really helpful guide with additional links. If you see the top of that picture at the top, there are 3 links to really solid evidence-based protocols and medication lists to help us decipher, is this a safe medication in lactation? Should we take caution? What does that look like? And most up to date and most helpful with a QR code associated to it. So kudos to the KBC, great work. I mentioned to our birthing and non-birthing facilities earlier this year that we're also going to talk more about this when we visit in person. We're getting some good questions about substances in lactation, and those patients that have substance abuse disorder that we're helping through now postpartum. Is there a reference in that scenario? And the answer is we're working on it. So KBC and your lactation team, as well as many of our hospitals, are working together to create the next version of that. But how helpful. We find across the state that a lot of people say don't breastfeed or pump and dump, when in fact, most of the time this reference gives you way better specifics and timeline. So very helpful resource we wanted to share. Next slide. This is just a nod to the work that has been done by our colleagues to get our website up and updated. So again, for everybody across the state, if you're enrolled, awesome. If you're not enrolled, that's okay. We still want you to have the resources. So we just took some snapshots of our severe hypertension and pregnancy landing page within the KPQC website. Let's take a look around the website. It has NAS information, it has for trimester information and resources, and then stay tuned because the severe hypertension and pregnancy resource lists, toolkits, you see that in the middle there, the Kansas Cuff Project that talks about our pilot sites, provider resources for your providers, your OB and postpartum providers that have questions about any of the protocols or best practice models, all linked there. And again, other helpful links and documents, which is kind of the catch-all. But folks, everything, we're trying to get everything in one spot so that if you can't remember where that protocol was or where you saw it, hopefully you'll find it on this landing page. Take advantage, use those pictures and documents, and share widely. Next slide. Wanted to update everybody and again, give huge kudos to our enrolled sites, again, birthing and non-birthing, and also to our pilot Cuff project. This workflow that you see depicted here is kind of an updated version of our postpartum protocol and our hypertensive protocols, and just trying to make it really easy and streamlined for a patient, starting at the left-hand side, who has early and consistent OB care. Isn't that a huge goal? Get that patient in early in first trimester, assess her need, assess her risk status, make her comfortable, make sure that she feels solid about calling with any concerns or questions, and then again, move her forward if she is identified as a high risk patient for hypertensive disease. Listed on that left-hand side, we'll just chase this through. Again, helpful for everyone. This is hopefully the new practice model in Kansas. We're evaluating that patient in pregnancy for aspirin for prevention, of course, of complications related to hypertensive disease. We're educating the patient early on and frequently about the post-birth yellow, red flags and what she does when she has those. And then take a look, take a listen. Does she qualify for home blood pressure monitoring? And are your providers set up for that next step so that she knows the protocol to use and who to call with elevated pressures? If she's identified as a home blood pressure monitoring patient, and again, this isn't just for our cuff pilot projects, you can use this anywhere if you've got that ability. Education about how to do that blood pressure correctly. Again, what to look for in terms of symptoms of elevated concern and what is the follow-up that's expected. Please don't hand out cuffs without this plan. We've heard multiple times across the state and nation that a home blood pressure protocol is only as good as that education prior to the protocol, or lots of triages happen, lots of confusion happens, and lots of frustrated providers also happens. So important part of that embedding. We know that we increase the surveillance both of the pregnant patient and the fetus during hypertensive disease. We should absolutely look at her social needs. Those SSDOH screens are vitally important because oftentimes there's increased stressors with these diagnoses for obvious reasons. And then, of course, the importance of OB navigation and using community health workers, doulas, OB navigators, nurse navigators, and connection to providers to make sure the patient has a full scope of care. Finally, the oh no moment. If she's got either red flag symptoms or elevated blood pressures at home, what do? This is what the state is also very focused on. And you're going to see in a minute that we're making some headway. Timely treatment. From the time that she arrives with severe range pressures, we are timely treating in under an hour severe range pressures based on best practice models. Then what happens next is she followed up antepartum because she's still pregnant, she delivered, and then how are we following up with that to make sure that she becomes healthier, stays healthy, etc. Again, find this on our website, share it out widely. Next slide. This is a repeat. We can go past that. And then we talked about the cuff project with our sites that are handing out blood pressure cuffs at the bedside. For those of you that are not enrolled in the cuff project, know that there's tremendous work on the Medicaid side as well as our private payers to connect to figure out how to get cuffs in the hands of patients that need them for home blood pressure monitoring. And we're making headway. We're trying really hard. Dr. Bettinger is at the helm of that work, and making it as simple as writing an order, perhaps even in the EHR, and the patient would get a blood pressure cuff with education to go home. So again, I keep teasing this, but sometime soon we're going to get this figured out so it's as easy as it's supposed to be. Next slide. Carrie?
All right, I'm jumping back in. You guys should have received, if you're an enrolled facility, you should have received an email through KPQC with links for additional seats. I just want to remind you guys, the goal of this is to offer you seats to train any new employees who haven't received post-birth training. It's not intended to do a retraining of all of your employees. So if you've already done the training, you've done the training, but I do know what the turnover in healthcare looks like, and I know what the continuation of that training takes. So if you have any questions on how to utilize those seats or how to do any group trainings or anything, please reach out and let me know. Next slide, please. Also, I know you probably are tired of hearing me say this, but if you have not sent me your breastfeeding/pumping protocol, please do so. If you do not have one and are needing some assistance with getting that done, please reach out to me and I'd be happy to set up a meeting and we can talk more about that. I can send you a templated one from a facility similar to your size so that you guys have something to kind of work with, and I can send you the literature to help guide you in that process too. But we want to just remind everyone this is our neonatal component of this bundle. We have a lot of moms who deliver early related to preeclampsia and severe hypertension. And with that often comes babies who end up in the NICU. So the best way that we can help that mom, especially as she's feeling like she has no control in that moment, is to get her pumping in a timely manner and get that manual expression going if the pumping is not an option and we're transferring her. Next slide, please. All right, Tara.
Yeah, actually, Carrie, I think let's get past this. You guys, we would love to hear from some of our sites as you're hearing the data that you're doing from our mouths. Raise your hand, jump in, and tell us some great stories or some challenges. For those folks that haven't been hearing your stories or from some hospitals, we know that there's some struggles happening out there with timely treatment or with identification of patients with hypertension, even in the EDs. So let's go through some of the, Carrie, I'll have you review the
Yep.
data pieces, but if you want to put in the chat, if you're interested in jumping in, we really want to hear from our sites today.
So Tara and I are definitely data people. If you haven't figured that out about us yet, it's the nerd in us that keeps us going. Um, so we wanted to highlight, just kind of give you guys an idea of the progress that we've seen since we rolled out this bundle. This particular slide, we utilize as our own 135 to give you guys your report cards at the end. So I'm going to pass through this slide right here. I really love the next two slides. If you'll skip this one, I'm just giving an idea of where you guys came at in baseline of 2025 and where we were at December. We still have through December of this year, 38%. I'm going to celebrate that. That's progress, guys. That is progress that you've made since the beginning of this bundle. Do we still have more to go? Absolutely. So would I love to see this at 75% or above by December 31st of this year? Absolutely. So let's keep working hard, reminding our staff of the protocols, making sure that everyone's educated on recognition, readiness, and response. And what the parameters are, making sure that you have ready access to the medications that need to be given in a timely treatment time frame. And then what can we do to help with provider education? I do know that that's a big part of that too. We only have so much control as nursing. So what can we do to advocate for those patients? And that's why we had the first few learning forums this year, so that we opened it up to talk to you guys about what barriers were you experiencing in order to get those patients treated in a timely manner. And I love those conversations. Next slide, please. This is also another data slide. This is the average percent of patients that were, again, treated within the 60 minutes. So we went from 30 out of 39 facilities who reported this data. 25 had patients that met the criteria. So this is keeping out those who didn't see any patients or didn't have any that met the criteria for this. We are increasing. So give yourselves a pat on the back. The work is being done, and we still have obviously room for improvement, but let's celebrate the positive and keep doing hard work. Next slide, please. And I'm going to pump this back to Tara.
Yeah. You guys, again, we talked about what becomes very obvious in the hypertensive bundle work. But quite frankly, when we look at MMRC data, when we hear from outpatient and inpatient providers across the state, it becomes increasingly clear that maternal mental health cannot be ignored, is not an easy thing to fix in terms of access and treatment and follow through, but also really deserves our attention. And if you think that conversation at the bedside at 2 o'clock in the morning is not an important moment for every provider and every nurse to know and to know what to do at that moment, as well as the triage, as well as the provider face to face in the room, or even e-chart patient messaging, and how we handle the moment where a patient says something that red flags or yellow flags for us about our mental health. Our family, they kind of are our family. Our colleagues at Kansas Connecting Communities has long been the state standard for best practice models and direct TA with everyone, and what tremendous work they do. Next slide. So this is just your gentle nudge about who KCC is. There's probably folks on the call. I haven't had a chance to look through the tremendous list we have, but uh, we often hear that folks don't know what to say or do, or how to send a patient to a warm handoff from the inpatient to outpatient setting, or they don't know how to refer a patient to services when they don't have them in their community. And this is the work of KCC. Um, Please ask for their help. Many of you have worked with them and likely need a refresh or likely need a reset because agencies may have changed in town or you're finding some gaps in care. Next slide. So this is one of two references or resources we want you to know about. The Mental Health Consultation and Resource Network. The phone number is provided there. It is a tremendous asset to our state. Anyone can call, providers included, and extraordinarily important for an opinion about what to do next and how to help each patient with individual care. Next slide. This is their contact information. Again, they are always ready and willing to help in whatever capacity or questions or resources you may need at your facility or in your care capacity, and didn't want to wait too much longer to remind you about their work. Again, certainly see the data coming through that tell us that we should probably bring this up about every month. And unfortunately, that's the case. So reach out to them, use their help. They're a great team. Next slide. Intimate partner violence. So from one hard conversation to another. We have worked tremendously. Again, many of you, enrolled and not enrolled, have been a part of education through the year on intimate partner violence. The CUES training was a huge asset in the last few years to everybody that is involved with the KPQC work, and how you have a global education, the assumed risk for every patient, and how that conversation comes about. The MAVIS group, the group in charge of that IPV work in Kansas, came up with this patient workflow. I wanted to share it with the state. You don't have time to read, and quite frankly, the words are pretty small to people at my age, but we will send this out. What a great visual to use on your units, to have as your education about how we have conversation and what do we do with the conversation when it's disclosed, or we want to do more for the patient, or she or he requests it. And how do we document? What's the follow-up? And how do we use CUES training in the middle of that? Wonderful, wonderful resource that we're going to share out. On the left-hand side, for those facilities that are enrolled, we're asking to finish this part of this important initiative with the community partnership agreement. It's simply saying our hospital continues to work with this IPV agency, may not even be in your community, maybe in an outlying community, but you refer and use services together for the improved outcome of the patient. So those of you that have received that agreement and are working on that, great. The rest of you will get it from me yet this week, and we'll tighten that up to make sure everybody has a warm handoff who needs it. But thank you to the MAVIS team for this work. And unfortunately, again, we know that there's more work to be done. Next slide. And then look at my exuberant exclamation points. Jackie finally gets to tell her story. Guys, ignore all the words. I just didn't want her to forget any part of what she described to us. And Jackie, I see that you're on. Hey, Jackie, introduce yourself to those that have never met you. I can't imagine there's anyone in Kansas that has not met you, but I think you should. And then tell us what you came up with there.
Wow, that's a lot of exclamation points. It makes me nervous. I'm Jackie Discree. I'm the director of the Women's Care and Birth Center here at McPherson Hospital. I have 20 years of OB experience and 25 years as a nurse as of this year. So did pediatrics first. I'm also a CASA volunteer. So all of the things that go into some of this work. So what we have is we have the process when our patients arrive, everybody gets a UA, and we take those patients into the bathroom, close the door. Every UA that anybody goes in and does on their own is contaminated. So we do lots of education about how to do a UA correctly. And during that time, we're helping, giving them their gown and getting stuff dressed. It's also a time that we can ask questions. We don't let anybody in there with us. And so we ask those questions. And if we have any concerns, then we can go from there as far as asking if they're safe, if there's anything they need or whatever. Well, about a year and a half ago, our chief nursing officer attended a workshop on human trafficking. And while we had a pretty basic process figured out for this, she came back and she's been very passionate about this. In December, facility-wide, every employee went through human trafficking education, from your EVS staff to your dietary staff to your radiology, your ER, your nurses, everybody went through this training. And so what we created, and this is part of our process as well, once we go in and ask those questions and we get a positive, comment from a patient, we can then use this human trafficking protocol to kind of help us figure out what to do next. And so, for example, in the ER, if there's a stroke or a STEMI or a trauma, they all have different colored folders that they use, red and green and yellow and whatever. And so what we wanted was something like that would not necessarily clue in the partner that there was a disclosure made, but would also give us the ability to get this patient to a safe spot if we need to, or to get that partner out. We are a locked unit, so we're lucky. We have a waiting room right outside our door. And if we are concerned, we can ask that patient, that person to go out there and wait. If we have somebody who discloses, then what we do is we come out and the staff alert either the house supervisor or myself, and they just say, hey, can you get the gray folder for me? Now, that means nothing to anybody in that room except for us. And so what we have is truly a gray folder. And I can call radiology because the ultrasound department is just across the hall from us. Pregnant women need ultrasounds, so it works out well. If I have to call over there and say, hey, can you bring me the gray folder? That's their clue that we have a potential issue with intimate partner violence or human trafficking that we need to get some things done. So what we do then at that point is they come over, or we get the support person out of the room and we bring the ultrasound in. It looks like nothing is going on other than we need to take care of our patient. Or we get them to a safe spot, whether that's, we're taking them to CT or lab. I don't have to take many patients to the lab, but I can. And so that gives them to that spot. Inside this folder, we have our policy, we have an evaluation tool, we have our resources. We kind of have some guidance about how to ask some difficult questions to kind of get more information. And with that disclosure, what do they want? Do they want us to call law enforcement to see what's going on? We recognize that an intimate partner violence victim may not be the same as a human trafficking victim, but the process can be very much the same. If they choose to disclose to us, but they really don't want anything else done, we have a couple of things. We have our Q's cards. They can have one of those. We try and get that to them because that'll fit in that nice shoe or inside the back of your phone. If you've got a phone case on, that can fit in there if it's not, if it's not clear or anything else. We also have a pin that everybody gets. The cool thing about this pin, and we show them this, is on our little ink thing, is the phone number to the domestic violence hotline. And so it just looks like a pin. It doesn't look like anything else. And at that point, then we can figure out what we need to do with them, what resources we can get them to, how we can keep them safe. But again, it all has to do with this gray folder. Anybody in the hospital can call for a gray folder. They can call up here and tell me, hey, Jackie, can you bring me the gray folder? That's my clue to figure out. First of all, call the house supervisor, let our chief nursing officer know wherever that patient may be. They could be having a CT scan done. They could be having an ultrasound done. But one way or another, we're hoping to find that information out and get them to a safe place. So far, we have not had to use it that I'm aware of, but it's also not something we broadcast across the hospital. Hey, we used the gray folder yesterday. We're a small enough facility that will happen. We'll know about it, but it very much has made a process that can be difficult to know what to do with. We've now got some resources. The policy's in there. We have a social worker now. We have not had a social worker for a long time. We now have a social worker here who is also involved, and we can call her. She knows all the resources. And so hopefully with our intimate partner violence and our human trafficking victims, if we have some, we've got a process figured out to help them get where they need to be if that's what they choose to do. That's been one of the hard things, is to realize, and my staff and I have talked about it, is what if you do have somebody who's like, yeah, I don't feel safe at home, but they don't want anything done? That's the hard part. And that's something that we have to accept, and we have to move on and, be very cognizant. We don't close doors in those postpartum rooms. We keep those rooms open, those doors open. We make sure that we try and talk to that patient some more without that person there, but it doesn't always happen. But we also always make sure that they've got those resources. At least the Q's card can go home with them, and so that other person may not ever even know it's there. So something we've come up with, like I said, house-wide, everybody knows about this process, EMS, everybody. And it has been a lot of really good education, has kind of become a passion for us as a nursing staff and nursing directors and our CNO here at the hospital.
Jackie, thank you. What tremendous work, and again, widespread, even within your facility, and that everybody is in the know about that. Do we have any questions for Jackie about that process or conversation about what you're doing at your facility?
I have one question.
Hi, Tessa. Go for it.
Hello. When you mentioned that you provided house-wide education, was that virtual education, or how did you manage getting everybody trained?
We created the education, the CNO created the education, and we went through HealthStreams. HealthStreams also has a standard canned human trafficking module that you can do. We also had a nursing skills fair last June where all of nursing staff was required to attend. And during that, our CNO, again, like I said, she became very passionate about this after she heard the stories. One of the stations for the nursing skills fair was her away from the rest of the crowd talking specifically about human trafficking. And so that was how we got everybody, as far as nursing staff, involved. As far as the rest of the staff, they all had to complete that HealthStream module.
Very good. Thank you.
Hey, Jackie, how does that work with local law enforcement? Do they come in when you make that report, remove the person that came with them, or how do you guys partner with local law enforcement to help with this?
And that's one thing Dara has done really well, is kind of explained our process to them as well. We don't have security here in McPherson. I have a couple of big maintenance guys, and I have a couple of big EMS guys that if things got really escalated, we would at least hopefully have somebody here. But otherwise, yes, we would if they chose to not leave when we asked them to, we would have to call law enforcement to come.
I was talking to a colleague last week about the outside of the box ways that obstetric and neonatal providers of all versions take care of patients real time. And how do you train for that moment? We talk about simulations, and that out of simulation of, like, let's say postpartum hemorrhage, right? You're nailing it and you're just boom, boom, boom. And the next step is to pull yourself back and say, and the significant other is next to, I'm not talking about IPV, but I'm saying, like, to see the whole room or to see the whole community is a whole nother level of workflow. Seems like the wrong word to use, but I hear you all's story, and Carrie and I have the great benefit of at our roles hearing what you're doing to take care of patients where they are. And kudos, Jackie, you're a perfect example. Tessa's brain's working, I can tell, there in Salina. And we know that there's name after name and hospital after hospital that's doing great work. I'm impressed. Carrie, follow up today?
I just went completely brain blank because I'm thinking about Jackie, and I'm thinking about the human trafficking education that I'd done previously in my previous role, and how prevalent this is. And you're talking about the pens that your ER is creating, and I know Safe Home has those pens. They're pretty phenomenal. And it just has this tiny little slit where a whole thing rolls out of it and then retracts back in. But you would never know just looking at it that it has all the information that you need from it in the pen. So that's another resource too.
I think one of the things that we all want to say is, well, it doesn't happen here. It doesn't happen in my community. And one of the things we learned with all of our education that we had a speaker come in and do, as well as we had a human trafficking victim's mom come in and talk to us as well. We are, like many of you, we are right on the interstate. We have a big Love's truck stop over across the way. If you look up where your massage parlors are, you'd be surprised. And how many of those are involved, may be involved in this same type of, and it does happen. It happens everywhere. And I think that, and then the person whose mother came and spoke, I mean, I'm in McPherson. I live in Great Bend. Believe me, this was between here and there that all this was happening. So it does happen everywhere.
And I would say, just wearing my hat as the abstractor for the Maternal Mortality Review Committee, the things that I see throughout our communities in the state is such an eye opener. So definitely, I encourage everyone on this call to stay open-minded and be aware that you may not know about it, but it's definitely happening.
Yeah, and I think
it's definitely happening.
It's become, for our staff at least, we've become pretty vigilant, hyper vigilant almost. If we see a patient come in to deliver, and most human trafficking victims may not be coming in to have babies, but if we have somebody who even comes in and seems to be very controlled, like they don't get to answer any question, the person that's with them answers all of the questions, those red flags just start going up. And I don't know that we were as vigilant or as observant of that until we went through this training.
Yeah. Well, food for thought. That's definitely an opportunity that we have on the PQC side of perhaps doing a learning forum that would open up some education in that too. So, Jackie, I really appreciate you speaking today. Do you have any other questions before I move on? Okay, well, as you guys see on the slide in front of you, I just wanted to remind everyone of the dates that we have coming up for the rest of the year. As Tara mentioned earlier, May 1st is our spring work day in person in Topeka. If you're an enrolled facility, the sign up for that has gone out. Please make sure you get registered. Our next learning forum will be June 23rd. And you see the rest of the dates on there for our subsequent learning forums after that. Is there a slide after this, Tiffany? I can't remember. Yep, perfect. And the title for that is our TMAW grant, which is transforming maternal health and how it works for Kansas. So I'm excited to be able to share with you guys additional work that's happening throughout the state with partners, not just with the PQC and the work that you guys are doing. So hoping you guys will join us for that. Next slide. And that's a wrap. You guys are gaining a little extra time back today, unless anyone has some questions. Okay, thanks so much everyone for joining us and have a wonderful rest of your week.